Welcome to the ACP for AA podcast. ACP for AA is a national education initiative of Heart Tones, promoting informed healthcare decision-making through advanced care planning conversations. This special 4-part podcast series highlights conversations with people who are working to close the healthcare disparity gap for African American families and communities. Today's episode is hosted by Terry James Taylor, Director of Community Outreach at Montgomery Hospice and Prince George's Hospice, with special guest Dr. Shahid Aziz, a pediatric team physician there. They'll talk about a question many people ask about, the different types of ACP forms. Let's take a listen now.
Hello, and welcome to our podcast. My name is Terry James Taylor, and I'm your host. Today, our topic for decision is advanced care planning and the many forms associated with it. Our guest with us today is Dr. Aziz, an expert in hospice and palliative care physician with decades of experience in having conversations on advanced care planning. Welcome, Dr. Aziz.
Thank you. Thank you for having me. I'm Shahid Aziz, and hello all. We are talking about a topic that is very dear and near to my heart. In my career, I started as a pediatrician, but then end-of-life issues sort of called me, and I am now do only hospice and palliative medicine, helping children and adults near the end of life to gain as peaceful and as comfortable and as satisfying end of life.
Okay, thank you. And today we're going to start off with a little bit. Can you explain to us what advanced care planning is?
Yes, absolutely. So advanced care planning actually is a process that is essential for all adults at any age, regardless of their state of health. So whether they're well or ill, and it helps them understand and share with family and healthcare givers their personal values, life goals, wishes, and preferences regarding future quality of life and medical care. And advanced care planning may include the completion of an advanced directive, which can include a living will, indicating treatment choices near the end of life, and a durable power of attorney designation for healthcare decisions. So the intent of advanced care planning is to see that patients receive treatments and care that is in accordance with their goals, values, and beliefs. And by the way, the advanced care planning now is an essential component of anticipatory guidance, which is the physician's responsibility. And it is no different than advising about other healthcare issues that we talk about, like weight control, cholesterol, smoking, drinking, drugs, etc. So it's not something that you should feel, oh my gosh, I cannot do advanced care planning because I'm in pretty good health right now. Okay. So, and I believe that advanced care planning is the key to decreasing suffering at the end of life for all concerned, which is patient, family, friends, caregivers, and the healthcare team as well. And advanced care planning is prevention against crisis-driven, desperate, irrational, emotional, and expensive decision-making. So you can see how important this issue is.
Very much so. Thank you. Now, is advanced care planning only relevant at the end of life or when you may have a serious illness?
No, actually, advanced care planning now is part of our anticipatory guidance for all adults. I mean, I did my own advanced care planning like 20, 30 years ago. And by grace of God, my health was good and is good. So the question comes up is, well, then why do I need to really do it, right? Why do it? So the answer to that is your decision-making capacity. As long as you have the wherewithal and the awareness that you can make decision based on information, you really don't need an advanced care planning, right? Because if I'm let's say your physician, and you have the capacity to make decision, I can just talk to you about your goals and wishes and treatments and all concerns. But you never know when you may lose your capacity for making decisions. And this can happen in a flash from multiple reasons, from, let's say, trauma, illness. And on a personal note, my sister-in-law, just about 3 months ago, had a sudden bleed in their brain and lost the capacity to make decisions in a minute. And if her daughter and she had not had any conversations, we would have been very difficult for us to make decisions for her. Mm-hmm. So by having these conversations with your family and hopefully even making an advance directive, you're helping, you're giving the best gift you can to your family. If they have to make decisions for you, that they know what is important to you.
Okay, so to summarize, advanced care planning is the basic process for how you would want to live near the end of life or when you're unwell. Now, what is an advance directive and how does that relate to advanced care planning?
Advance directive is the written document that talks about what kind of a quality of life is important to you, what your wishes are, if in certain states, what kind of treatments you may or may not want. And it also talks about your designation of someone that you trust, that you want to be the decision maker if you cannot make your own decisions. So we call it the power of attorney for healthcare decisions. Mm-hmm. Okay. So this is a person who you trust, who knows you well, who knows your wishes and your goals and what's important to you. It does not necessarily have to be a family member. Most of the time it is. Preferably pick somebody younger and somebody not very emotional. If you have, 5 children, pick the one that is the most stable and the most thoughtful. They have some hard decisions to make that they can stay focused on that and can be a support to you. So I've had patients who's, either a son instead of the husband, grandson or granddaughter, or even a nephew has been the decision makers.
Dr. Aziz, can I ask a question?
Yes.
Have you ever run across any family members or a patient that didn't have a family member to do it, that it was somebody outside of the family that
yes,
they felt could make better decisions than the family? All the family members could be emotional.
Absolutely. Yeah, it doesn't have to be a family. But what you do is once you choose the healthcare agent, your job is to talk to the healthcare agent and see if they can support you in your wishes. And then you let it be known to everybody that you have chosen so-and-so and maybe even why you chose so-and-so. So there's no fighting between family and no resentment.
Okay, thank you.
Mm-hmm. The advance directive is essentially containing the gist of the conversations that you've had during your advanced care planning process. So the whole thing goes is that you first have those discussions about your goals and wishes and values and how you want to live and not live with your family. And then you put them down on a document in addition to designating the power of attorney. And that becomes your advance directive. Advance directive that you make today is not etched in stone, and it can be revised at any time that your goals and wishes change. And if you were to ask me if all of this, the most important thing is having the conversation, because many times you have not made the document, but since you've had the conversation, your family is able to tell us what you had said, and that can help them in the decision making. I can give you a very quick case about that. So we had a lady, she had a mild dementia and could not make decisions on her own, but she could still talk with her family some. And she was in her 60s, and she had trauma to her leg, infection and gangrene of her foot. And the physicians wanted to amputate the foot to save her life. Otherwise, she would get septic sooner or later, and her life would be very short. Her life was short because of the dementia anyway. So when talking to the family, we were told that she didn't have anything in writing, but she used to say that I never want to lie in a bed of affliction. In other words, never leave me so sick that I can't even get out of bed. And I just don't want to live like that. And don't just keep treating me and just keeping me in the bed and nothing more. So based on that one sentence, the family was able to make a decision to not have the amputation, put her in hospice, take care of her, love her, keep her comfortable, because she was already partly in a bed of affliction, and after an amputation, she would be totally. So they were at peace that they're doing the right thing for their mother, because it was based on her wishes and her comments.
That helps a lot, because then you still, while you're in the right frame of mind, have the opportunity to let your family know what it is that you want, how you want to be treated, what your goals are, and different things like that.
Right.
Um,
And that's why the time to have this conversation is now. I mean,
Mhm.
today, because
Mhm.
we don't know what tomorrow is going to bring.
Mhm. So, Dr. Aziz, so you're saying that it's often better to do advanced care planning before anything happens, so you can think through your choices without any additional stresses. Some people may ask as well, what about now, or would it be better to do it later? But the reason to talk about it now is that you don't know when something might happen, or you might lose the faculties to express your wishes. That's on your family members as well.
Mhm.
Um, there's so many different forms out there. How do we know the difference and what's best?
Yeah. So we are. If you go to our website, actually, we'll be mentioning some of the forms there that one can look at. So the question is, which form suits you best? I can't tell you, only you know. So you'll have to look at the different forms and see which one suits you best. But interestingly enough, to me, the best form really is that comes from you. It is your wishes written down on a piece of paper by hand or by or typed, and then you can have it signed and have two witnesses sign it, and that is a legal document. You don't need a lawyer. You do not need a notary public in Maryland even to sign, to witness your signature, but two witnesses. The witnesses cannot be your close family members, especially those who may benefit from your estate. So best is to get a friend, neighbor, or somebody like that to witness your signatures. So get familiar with some of the forms and see which ones you like. But in any form that you use, you can always add your own words to it, so that your own minimal levels of acceptable life, the quality of life that is important to you, you put that nice and bold, and most form have spaces for you to put your own goals in there, including the Maryland the advanced directive form. Actually, the very first question is, what are your goals? So right there, you put your goals of minimum acceptable living is that mentally you want to be able to do X, Y, and Z, and your minimum physical levels and any treatments that you do or don't want. And I'm going to give you a few examples of advanced directives that patients had written in their own words. So after we went through this process of advanced care planning of the three questions, which I suppose we'll probably be talking about later, they came up with their advanced directive. And you can see how simple it can be. So here's the first one. And this is by JJ, and these are not the real names, so but these are real patients. So JJ was a 78-year-old with a long history of diabetes and chronic lung disease, and was now complicated by hospitalizations over the last 2 years in heart failure. So she was on continuous oxygen at home, but she was able to get around with difficulty. She still had her capacity to make decisions and enjoy her meals. So I talked to her about end of life wishes, and this is what she said.
You are listening to the ACP for AA podcast. More coming up after this quick break.
ACP for AA is a nationwide educational outreach initiative, partnering with organizations to help bridge the racial disparity gap in healthcare delivery by providing credible and culturally relevant healthcare-related information and resources, promoting conversational engagement about advanced care planning options and preferences, and preparing the necessary steps to complete advanced care documents and choose a healthcare advocate if unable to speak for oneself. ACP for AA, an initiative of Heart Tones, is pleased to partner with Montgomery Hospice and Prince George's Hospice Center for Learning to provide ACP resources to citizens of Montgomery and Prince George's counties in Maryland. Visit acpforaa.org.
Montgomery Hospice and Prince George's Hospice is a nonprofit healthcare organization that provides hospice care to residents of Montgomery and Prince George's counties in Maryland. Our interdisciplinary team includes physicians, nurses, spiritual counselors, hospice aides, bereavement care, and volunteers. And we also provide complementary therapies. To learn more about our services, please call 301-921-4400 or visit us at www.montgomeryhospice.org.
So she was on continuous oxygen at home, but she was able to get around with difficulty. She still had her capacity to make decisions and enjoy her meals. So I talked to her about end of life wishes, and this is what she said. Number one, I do not want my life prolonged by any means if I am unable to communicate with my family verbally or by gestures, even though I may be able to recognize them. So here's a patient, she's saying, I may know who you are, but if I can communicate with you, I don't want my life prolonged by any artificial means. Number two, if I cannot get out of bed myself, please let me die in peace and do not extend my life by artificial medicines or machines. Number three, always make sure I'm pain-free and not suffering. Number four, I do not want to be resuscitated if my heart or breathing stops. So she has already made the decision that she has a fairly difficult life as it is. And after cardiac arrest and her heart and breathing stopping, when you resuscitate those patients, they'll be even at a much worse state. And she didn't want to go through that. And number five was that I do not want to be tube fed if I cannot enjoy food. So enjoying food was very important to her, and if she couldn't do that, her quality of life she would not consider quality of life good enough if she's only kept by artificial feedings. Because I'm sure many of you have seen patients who are on artificial feedings. And that's it.
Okay. And Dr. Aziz, I have a question about all of the things that you mentioned, and especially when it comes to communities of color, preferably the African American community.
Yes.
Even having those documents written with the trust issues that are within several different communities of color, how do one, as a doctor, assure them that what they put together, not necessarily notarized, but everything that they put down, that the doctor themselves are going to follow those instructions? I don't know it's by law. I know they have to, but how do we convince a family after the lack of trust within the healthcare system that their wishes are going to be met?
I think there are actually a couple of very important processes by which they can be reassured. The first one is, so the best way for you to assure that your wishes are understood and honored is to have the open, frank conversations with family, with your power of attorney who's going to help make decisions for you, healthcare decision, and the physician ahead of time. So now's the time to have those conversations with them. And then your POA, who is designated to help you to follow the wishes. So you need to have very frank discussions with them and say, this is important to me. Can you support me in that or not? Because you're absolutely right. I've had patients where once the husband lost the capacity, even though he has stuff written, the wife wanted to do something different. So you need to have this discussion with them, and preferably with your physician also. So the physician can reassure you and put them in writing. Without those documents, without those discussions, you have no idea what's going to happen to you. And the families are going to be in turmoil and in conflict.
And having said that, I think that's why it's more important to do it when you're well than when you're not so well.
Absolutely.
There's a lot of different forms around advanced care planning. And we have the 5 wishes, and you can go to mydirectives.com. You can also refer to our website for the different forms that we provide.
Right.
By going to montgomeryhospice.org.
So let me share another patient's advanced directive or their goals with you, which again, like I said, can be added to any form that you like because they have space for it, or you can add in addition or just write your own. So this gentleman said, name is WB, I'm going to call him. He's 86-year-old with congestive heart failure, pneumonia, and again, severe lung disease. And he said, I do not want life prolonged by any means if I cannot recognize and communicate with family. I also wish to receive no curative treatments if I'm totally bedbound or unable to eat and swallow. I'm willing for short-term intubation if it can help me achieve the level of life as described above. So he's talking about treatments that he's willing to take and for how long, as long as we can get him to that level. But if we cannot, then we don't have to. And I do not want to be resuscitated for cardiac arrest. Again, he wants to be do not resuscitate. And he also talked about dialysis. He said dialysis and other treatments are okay, only if it will help me to achieve mental awareness level as described above and physically not be totally bedbound. And I want only comfort measures only once it is clear that the minimum levels cannot be achieved as described above. And I wish to die at home whenever that time comes. Okay. So you can see that with those, his own words, the goals become very clear. And if the family had to make decisions for him, they would know what the boundaries are. What I also want to emphasize is that it is very helpful for you to talk to your physician about what your wishes and goals and treatments options might be, so that he can talk to you about the pros and cons of each, so that your decisions are then made on informed information and not based on any wrong assumptions. So just in case, so it'd be good to run that by your physician. So what you could actually do is write your advance directive, sign it, have witnesses sign it, talk to your physician. And if you have to change something, like I said before, it's not, written and etched in stone. You just go ahead and rewrite it and then have it re-signed. Okay, that'll be a very quick, practical way to do it.
And Dr. Aziz, is that something, if people wanted to, could have in their medical chart with their physician?
What you really need is a written document that you can easily carry with you. When you go to the hospital, you can give it to the physicians. You can make copies and give it to your family. So it needs to be a separate document because you're going to have witnesses sign it. But once you have the document and you give it to the physician, he can put it in your chart.
Mm-hmm. And you can change that directive as many times as you want. There's no limit.
So what we usually say is that, let's say you made one today. Mm-hmm. In a year, perhaps review it, or in before that, if you get sick, every time you get sick, review it to see if something needs to be changed or not, depending upon what happened to you.
And that's good to know, because I'm sure a lot of people are not familiar with that or may not know that they have that option.
No, absolutely.
Thank you for that great information, Dr. Aziz. Now we're going to move over into the community questions. Okay. Sometimes when you don't know what decision to make, people think not making a decision would be the best. How do we deal with that uncertainty and putting something down on paper?
So they're afraid that since I don't know what to write, let me not write anything.
Mm-hmm.
Again, I think you're going to need some help with having the conversations with either knowledgeable people, your physician, so they can guide you in the decision making. So I have this simple process. That's the way I look at. The process I provide is called the 3 questions. So you don't know what decision to make. So the 3 questions say that everyone wants their life to be meaningful. They want a quality of life that is meaningful to them. So how do we figure out what quality of life is meaningful to us? You start thinking in terms of the lowest level of function that you would say, as long as I can do the following, it is still good for me. So the first question would be, what is the lowest mental level that you would like to function at? That you would say, this is still meaningful to me. And if my life is being prolonged where you're giving me some medicines, or you have me on a cardiac pacemaker or dialysis, whatever, it doesn't matter, as long as I can do the following. So the easiest way to think about different mental function is to start with the lowest function, which is total unconsciousness. And I've yet to see a patient who says, yeah, if I'm totally unconscious, this is still meaningful to me. And the next level would be semi-conscious. And these are patients where you would say, when we are saying total unconsciousness, we are saying that the doctors have said there's no chance of recovery. You've had such severe disease.
Mm-hmm.
The next would be semi-conscious. You can look around, but you have no idea what's going on. The next level would be a little bit better than that, which means you can focus on people or things, but you have no recognition as to what it is. Next is that you can recognize people. And the next would be that you can recognize and communicate with people. And the next level, of course, is that you can have great conversations and, make jokes and all that, and you know exactly what's going on. Okay. So we are looking for a lowest level. And in my experience, most patients want to be able to recognize their loved ones and want to have some kind of a communication with them. There's some who say, as long as I can recognize, that's fine too.
Mm-hmm.
So that one of those probably will become your lowest acceptable level. And then you think of the physical low levels. And I would think in terms of the ability for being mobile to get around with or without help. Think about the means of being able to take care of yourself, especially toileting, etc., and the ability to swallow and enjoy food. These are the 3 major things people talk about. So if you can kind of think of the lowest level there, then you can start putting that down. And the treatments, if you have had experience with certain treatments that have been awful and you don't want to experience them again, you could say, I don't want that treatment. If you're in a life-limiting illness and in a very poor state of health to start with, you may want to talk to your physician about not being resuscitated, because that'll only make your life more miserable. But the treatments you'll have, you must discuss with your physician and say, I'm thinking of this and thinking of that. Am I making the right decision? Okay.
Thank you. Now, Dr. Aziz, what happens when a family member refuses to do any advanced care planning or complete an advanced directive?
So trying to convince them that this is a good thing, right? That's essentially the question. What I would say is that you can try different things. One is to convince them to talk to their physician about why it is good or not good. If that hasn't happened, you can give them literature to read or internet sites to go to that talk about the need and why of an advanced directive and advanced care planning. There are blogs also that one can go to that will help you with this. And again, if you go to our website, www.montgomeryhospice.org/advanced care planning, we have information there as to which kind of sites will be a good, helpful site for looking at advanced care planning. You could also say to these family members, let's say you're the daughter or the son, okay, talking to your parents. So you're saying, God forbid, if something happens to you and I have to make decisions for you, I would like to know what is important to you, what quality of life is okay, what is not okay, so I may be able to honor your wishes. And I can do that if you don't have a conversation for me, or don't tell me what is important to you, or don't make an advance directive. So that would be one reason. Another thing you could say to them is that doctors are having these conversations for all their patients, young and old, to prevent unnecessary pain and suffering. And can you at least talk to your doctor about it? Okay. And you can give them example of people losing their decision-making capacity in a hurry because we don't know when that might happen. She said, Dad, what would happen if you had a stroke, or you were in a car accident, or you get dementia, or you get really sick with meningitis and you can't make decisions? Then the burden is on our shoulders. We need to know from you what is important, because then we know that we are doing the right thing.
And Dr. Aziz, my next question too, what if a family member doesn't agree with my choice?
So again, the question here is that family member doesn't have to agree with your choice. He just has to honor your choice. This is your choice. This is my choice as to how I want to live or not live. So you will have to have that discussion with the family member. And I probably, if they don't agree, I probably would not choose that person as your POA.
But right. But I'm saying, in making those decisions, a lot of families will sit down together with everyone to make decisions and to talk about it. So
in that case, let's look at the scenario. You're in the hospital, you're very sick, you can make decisions, some decisions have to be made, and the family is in conflict. Some are saying one thing, some are saying another. So there are two very good ways to resolve that. One is to ask for a palliative care physician consult. So if you're in the hospital, you ask for a palliative care consult. And these physicians and social workers have done this many times, and they can help you look at the pros and cons, help you look at the big picture. And that's what I do when they call me. Many times I have to do that. Look at the big picture and have you see what is right and what is not wrong for the patient, and hopefully help them get through this. The second would be you can ask for an ethics committee consultation. Almost all hospitals and institutions have to have an ethics committee to help resolve such issues also. So those are two things that you can make use of.
Okay, and I have one more question. How do we handle the same scenario if we're doing it when we're well and we don't have to have a palliative consultant or anything like that? If we decided to make our directives when we're well and nothing's going on, but yet we still have that conflict within our families. I'm well, and I write out everything that I want. I share it with my family, but they are still not on board with what I'm trying to do. And so that can have me to be stuck between a rock and a hard place, because I don't need to talk to a physician because I'm well, but I'm doing this, but yet my family is not in agreement with the decisions that I'm trying to make for myself for when I do start declining.
You might need a knowledgeable moderator person to help you with that.
Or like we said earlier, it wouldn't necessarily be my family member. I may be able to share and let my friends or whomever know.
Most important would be to at least find a POA who is able to support you. Mm-hmm. And you can make your document with the POA supports you, and you can have it in writing. You can talk to your physician, and you can talk to your physician and say, my family is not helping me. So they can maybe get you counseling with a social worker or a chaplain, or do it themselves, or whatever they think is appropriate. So I think you're going to need help with a third party.
Okay, thank you.
A mediator, yeah.
So I think at this time we're going to wrap up. Thanks for all the questions that you answered for us. And if there's anything else that you would like to leave with us, Dr. Aziz, any pearls of wisdom?
I just want to say thank you for having me. And I can't stress enough, I believe this is the key. This is the key to decrease suffering in people. And this is the key to have you your end of life be as good as possible, as peaceful as possible. So please have the conversations and look at the website and please have the conversation. All right.
Okay.
Thank you.
Thank you, Dr. Aziz, for joining us today to talk about advanced care planning and the forms associated.
Thank you for listening to the ACP for AA podcast. We can bridge this disparity gap one individual at a time. First things first, let's talk about it. We encourage you to visit the website at acpforaa.org for more information and resources.